Good afternoon, everyone. I'm Dr. Lisa Tartaglia,
Dr. Sarah Bone.
and we're coming to you today to talk about hospitalizations and specialists in 1 year time.
Based on your hospitalization history and the number of specialists, it can indicate a lot to us about your illness and how serious it is.
And I think that oftentimes when we receive a palliative consult, we are going in because these patients have chronic illnesses and serious illness and maybe disease progression, and we're faced with shock and disbelief, and from both the patients and families.
And they've maybe been told by their specialist, everything is good, and maybe what they should have said is, for what's happening, you're doing okay. Because everything is not good. That's why you have to go see the specialist, and maybe that's why your medications are changing, and maybe that's why you're not feeling as well, not feeling as strong, maybe you're losing weight, but things are good for where you're at.
Right. We'll hear things like, oh, we were never told that we were that sick. What do you mean there's no cure for this disease?
You're the first one that ever told me this.
And then there's a lot of personal, I don't want to say failure, I don't know, you have to help me come up with the word, but when I tell you the question is, we hear a lot of the patients say, why is this happening to me or to us?
And that's not any fault of yours, or it's not our body. We are mortal, and changes do happen, and diseases do take their toll on us. And so our job is to help you understand where you are in your disease stage, what your state is. Certainly you want to know what the disease state name is, and you want to know the stage of the illness and how it's progressing, what it's likely to look like over time, so you can help plan and you can be proactive.
Right. And sometimes when we go in to do a consult, we're approached with such relief because the loved ones have seen a decline in their person, and even the patient has seen the decline, and they keep bringing it up to the healthcare team, and they're just bombarded, well, we're going to try this and we're going to try that. And it's, the paternalistic view of medicine that is slowly going away, and also a view for physicians that believe that we are immortal, which is not true. We are mortal, and they don't want to. They view it as worsening of disease is giving up, or maybe they're not good enough physician.
And it's not about giving up. I know I took care of a patient not too long ago that had advanced memory impairment, and they had a separate process in addition to the memory impairment of not being able to swallow. They'd had some scarring in their swallowing tube. They'd had a dilatation procedure done many times over the past 10 or 15 years from chronic reflux. And so they couldn't bolus and swallow very well because of their dementia, but then with the added change of their esophagus and they're like, it's not, it should milk to make that food go down, it's not going down very well. So they have a lot of swallow problems. They had a pneumonia, they got a urinary tract infection, they went to the hospital, and so they're going to put in these different tubes. Well, I guess the patient kind of came alive, like with multiple arms and legs like an octopus, because when they're trying to put that tube in the nose, the patient is, basically saying, we're not doing any of that. He does have advanced dementia, so he doesn't know what they're doing is trying to feed him through a tube, but it's been like 5, maybe 7 days, and he's not had anything to eat or drink because he's having so much trouble with this dysphagia. So they want to try taking him to interventional radiology to pass it with a wire, and if that doesn't work, then they're going to try to take him to GI and put a tube in the belly, and they're just proceeding as if this is what the family wants. And nobody really asked them.
Yeah, and for us that's so disturbing, right?
We shouldn't assume what they want or what they don't want. So the team involved the palliative group, and we sat down and just asked them, what do you understand? What do you want to know? What are you concerned about? What are the assumptions that we're making? Are those correct about how you want this treated? And one of them, one of the older family members set forward and said, after we do this, is he going to be better mentally? Are we just delaying the inevitable? Because we know he's got memory problems, and then the swallow thing is kind of like that, but it's also separate. And you can go to choosingwisely.org, and we can put that in the description below, and it talks about feeding tubes in patients with advanced dementia. And that's not the major reason why this person's not swallowing. It's another reason from a scarring process. But the family's like, we're not sure we want to do any of these tubes. Well, the team caring for this person had never really asked the family about the outcomes. So this whole conversation really took a turn, a 90-degree angle turn from this is what we're doing to why. And the family was the one that asked the question.
That's awesome. I have to say, this is so awesome because I cannot tell you how many times I receive patients that have family that's not active in the care, and they're just going along with what the medical team does, and the outcome is horrific, meaning they'll get the feeding tube and the patient still ends up passing in several days to weeks because nobody has explained to them why the patient needs a feeding tube. So the whole point of our lecture today is really to talk about 3 rules of threes that we found that we use to help prognosticate and will hopefully help you all be able to make better decisions for your loved ones.
So the first rule has to do with the number of admissions that you've had regarding the same organ system not working correctly within like a 12-month time period. Has a person had like 3 heart attacks this year? Have they had heart failure exacerbation 3 times this year? Do they have advanced COPD or interstitial lung disease or bad asthma? Is there some reason the patient's not been able to breathe and had to go to the hospital? Fibrosis, asthma, what's happening with their lungs that they keep having to go back to the hospital?
Right. How about with their kidneys? A lot of times people just think, oh, well, they're in acute renal failure. But if you're going in and out of the hospital having acute renal failure for whatever may be the cause, there could be underlying damage to your kidneys. Also, even chronic kidney stones. Chronic kidney stones causes wear and tear to your kidneys and will also cause a renal failure. So it's really important to look at the cause, the underlying condition. Was it diabetes related? Is it infectious related?
Is it a genetic disorder?
Yeah, exactly. Liver is another thing, people don't realize, we do realize we're DOs, we're osteopathic physicians, and we learn from day one in medical school, the body is a unit. But the liver is a very essential organ. If it is not working because somebody has had underlying infectious process such as hepatitis, do they have end-stage disease of cirrhosis? Is it because of alcoholism? Is it because of the hepatitis?
A genetic disorder with their liver, or this new thing that we're seeing so much of, this NASH.
I know.
So some patients may have NASH. We see that so much now, and it's non-alcoholic steatohepatitis. So it's not anything they did. It's just their liver is building up these side chemicals. And I'm sure I've got a lot of GI friends who are going to correct me in the comments below. And
that's okay. We'll take the correction.
Yeah, I'll take that so you can butcher it. I'm sorry I butchered it. But sometimes it's not something that we did that earned this organ system to not work right. It just happens.
Right. And another organ system is GI system, right? It's a big system. There's a lot of things that can go wrong with it. And you don't realize, like, going into the hospital with like a peptic ulcer or a gastric ulcer, or even just indigestion, GERD, reflux disease. Going in and out of the hospital over and over again with these type of illnesses will cause a weakening system. People that have constipation, as we get less young, just like our heart doesn't pump as well, our blood vessels to our intestines don't work as well. So it's normal to have some underlying constipation. Well, that constipation can be fatal. Sometimes if you have a bowel obstruction, and that bowel obstruction causes a tear in your colon, and you have an infectious process. Nausea and vomiting, uncontrolled nausea and vomiting, like what happened with you're taking medications that no longer are absorbed correctly, that causes weight loss, that causes a nutritional problem to your overall body chemistry changes, and that may affect your mortality.
And certainly malignancy of any of these organ systems.
Yes.
If that's what's making you go back to the hospital and you're getting admitted multiple times in a year, it indicates that that's advancing.
Exactly.
That's a concern for us.
Yeah. So our number 2 condition of greater than 3 infections in a year is also really important to look at. And you want to take that also by organ systems. So a lot of times patients will go in and out of the hospital maybe having pneumonia. urinary tract infections.
Those are really common as we age. By definition, a urinary tract infection in a male is a complicated UTI. Men should not be getting urinary tract infections. Women, it's a little bit easier, actually quite a bit easier for us to get a bladder infection. A lot of that's just an anatomical, the way we're made, it's easier for us to pick up a bladder infection. But the only way you really clean your urethra is to void through it. And so as we age, our natural defenses against all kinds of bacteria decreases, and it's easier for us to get an infection.
Right. Plus the use of chronic catheterization, they also are set up for infection. The problem with infections is once you have a lot of infectious processes can occur throughout the body, on the skin or whatever organ they may affect, is when they become sepsis, where the patient gets a infection that is throughout the whole bloodstream.
And it's not as simple as just giving them an antibiotic, because over time those bacteria begin to get smart. And they begin to see, I've seen that antibiotic before and got me the last time, and they begin to learn about the antibiotics. And so we can actually exhaust our ability to fight some infections, and we get what they call superbugs. And sometimes those bacteria are things that other people can fight off and don't need an antibiotic for. And they actually don't recommend test of cure for people with a bladder infection, because after a certain age, we may become colonized with a bacteria where we kind of live together and it doesn't make us sick. And so we don't want to risk giving them an antibiotic, making them sicker, giving them a colon infection, giving them a side effect to the antibiotic, or making that bacteria smart enough that it's not susceptible to that antibiotic. When people say, I'm immune to that antibiotic, we don't want you to be immune to it. We don't want the bacteria to be immune to it. So it's semantics, but we want that bacteria to be sensitive. We want it to be susceptible to that antibiotic.
Yeah, and we just want you all to know is when you have all these infections, there's some underlying disease that's probably exacerbating or lowering your susceptibility and making you to get sick. And this is not good. It's not a good prognostic factor at all.
One more thing that we can see kind of in that same, hospital admissions is the dehydration.
Yeah. And dehydration plays a role. It can be because patients are not drinking enough when they come into the hospital, because they have urinary incontinence, so they don't get adequate hydration at home. It could be due to side effects of the medication that their hydration is affected. It may also be because of their kidneys are not working as well, and metabolism causing as dehydration, the antibiotics.
Maybe they can't get to the kitchen to get a glass of water.
Yeah.
Maybe they're in a facility and the water is, too far away, they can't reach it, or they have to have someone actually hold the straw up to them, and they just will take a sip or two now and then, and they won't really, drink 8 ounces several times a day.
Exactly. The third item that we want to discuss is greater than 3 specialists. I have to just, I've talked all the time about my elderly relatives, but they all loved going to the doctors, and they would be like so excited because I wanted to be a physician. So they'd be like, oh, today I'm going to the cardiologist tomorrow. And honestly, until I went to medical school, I didn't know how bad that was. But that's not something to be bragging about.
It was a hobby. It's a pastime. Yes. We're going to go to the doctor today.
It's not
a good thing.
It's not a good thing. It's not normal for you to have to routinely see more than 3 specialists in a year.
If you need a heart doctor and a lung doctor and your PCP, you're already at 3 specialists. And how often do you need to see them? And is your primary physician, are they coordinating all of these meds to make sure all these meds get along with one another, and that you're doing okay? You're handling all these medications well.
Yeah, and I think it's so important to talk about the coordination, because if you do not have a good primary care physician that's overseeing as the mother of the ship, then there could be a lot of drug-to-drug interactions. Some of the medications may cause harm and cause more symptom management. So it's really important to look at why your loved ones are seeing these specialists. Is it because the PCP like kind of has used all their tricks that they could?
And you have to, they
and
have
now
to have
you have
extra
to
help.
go to an endocrinologist because they cannot control your blood sugar. This is not good. You know?
And I know sometimes the patients don't want to go to those specialists, but we've done all that we can, and we need that extra help. I've had patients tell me, please, I'll do whatever you say, don't make me go to that specialist, because they know it's a worrisome thing for us to have to send them on to a specialist. And as a primary care physician, I'm not going to lose you as a patient, I just need extra help.
Exactly. So in summary, we just want to, we hope you learned a lot from our video, and we want to touch on when your loved ones or even yourselves are faced with unrelenting illness or a serious illness, it's hard to figure out the severity, and because we're in the moment, we're living day by day. Our patients are static, they're changing, your loved ones are changing, and it's really, really hard to figure out what's going on. We hope that our 3 rules of 3 help you understand how we prognosticate serious illness.
Helps us prepare the patient and prepare the family so that they can kind of see what's coming, they can have important conversations, and they make sure they keep that line of communication with those physicians open, and that the physicians communicate with each other as well as with the family and the patient.
Yeah, and we just want to address that medicine is no longer paternalistic. It's really about you. And if your healthcare team is not allowing it to be about you, it might be good for you to look for another healthcare team that might be better suited for you.
We're your employee.
Yes, because it's every patient can be different. We may have 10 patients that have all the same illnesses, and their management may be different based on what you, the patient, would like.
So include your physicians in those decisions, and if your physicians are using advanced practice nurses or if they're using PAs as physician extenders, it is really important for you to see that physician periodically as well as just the physician extenders.
That's really true and really important. It's important also to discuss with your loved ones. I'm just going to do another shout out to having goals of care conversations. They're so important. They really help loved ones look at the big picture. And you want to do it early on in disease process, because when we become desperate, we start to do desperate things. It's just natural inheritance of human nature. So just make sure that you're able to know what your loved one wants, advocate for your patient, and be aware of the 3 things that we discussed today.
Thanks for coming today. I hope you had a good experience with us and learned something valuable.
Have a wonderful day. Thank you.